Imagine you want to study physiology, but now you are hungry, so you first want to prepare some food before you can go on studying it. And you get in your kitchen, by mistake, you cut yourself as you are preparing that food. Blood comes out. You want that blood coming out to stop coming out. And so the platelets are going to do their job in making sure that there is coagulation or blood clotting. Now imagine it is just in a blood vessel. You are just walking, and then blood starts clumping together, starts coming together. What happens? It fails to move in the blood vessels. And so there's not going to be any transport of oxygen in the body. And you don't want that. So that is why we have got the anticoagulation pathway to prevent the coagulation of blood when you don't want it to coagulate. So simply, these are series of steps involved in preventing or treating blood clot formation in the process known as coagulation. Right. So we have got some proteins which are involved in coagulation. In the same way, we have got proteins which are involved in inhibiting coagulation. Now, these proteins which we have here are plasma inhibitors. Not necessarily that they are going to inhibit coagulation. Some of them, they might inhibit the inhibitor. We are going to understand what we mean. So I've got anthrombin 3, which works on antserine protease. We have got alpha 2 antplasma, which works on antplasmin. We have got alpha 2 macroglobulin, which works also on ant protease. And then we have got protein C, which works on ant factor 5 and 8. So the heaviest of these, the one with the highest molecular weight, is the alpha 2 macroglobulin. Even from the word macro, meaning big, it has got also the highest concentration. The one with the lowest concentration in plasma is the protein C. All right. So now, starting with the thrombin 3 that we've just talked about. So we have already mentioned to say it is a protease inhibitor and non-specific. It is produced in the liver and endothelial cells. Endothelial cells, simply cells in the blood vessel, cells which make up the epithelium of the blood vessel. So what anthrombin 2 does is that it's going to bind to serine proteases in the coagulation system. Now, these serine proteases, they are involved in clotting. So that is going to block. If this antithrombin 3 binds to the serine proteases in the coagulation system, there's going to be blocking of activity as clotting factors. So then there's not going to be any clotting. So that is basically what anthrombin is doing. We know that thrombin itself is the one which converts. Of course, we're going to have prothrombin converted to thrombin. Thrombin is going to convert fibrinogen to fibrin, which forms a mesh, and that is what now is going to prevent blood clotting. Now, anthrombin is going to prevent that operation of forming that mesh. So this binding, the binding of the serine proteases, is facilitated by heparin, which is a medicine. Okay, it is a naturally occurring anticoagulant. Heparin itself is a naturally occurring coagulant. We can as well use it in medicines just to do the same work that the natural one does. So this heparin is a mixture of sulfated polysaccharides with molecular weight between 15,000 to 18,000. So naturally occurring anticoagulant protein that inhibits several clotting factors. These things which are going to be inhibited by these anthrombins, we are going to have the clotting factor number 10, clotting factor number 9, clotting factor number 11, clotting factor number 12. Simply 9, 10, 11, 12. These are the ones which are going to be prevented from operating. Now, if we can look at them, all of them, they've got an A, meaning the activated form of these factors, the clotting factors, are the ones which are going to be prevented from working. Actually, what happens is that when the clotting factor number 12 is activated to 12, it converts 11 to 11A, which converts 9 to 9A and converts 8 to 8A. The 8A now converts 10 into 10A, but of course we don't have 8 here. So this is basically what we are seeing is the intrinsic pathway. So the anthrombin is preventing this pathway. All right. So we have already said that the anthrombin is going to act with heparin. It basically acts as a cofactor, meaning it works together with heparin in enhancing its anticoagulant effect. So when there is a deficiency of this anthrombin, it means that blood is able to clot anyhow, because this one is there to prevent the coagulation. So imagine the blood clots in the veins. We are going to have venous thrombolism. So you don't want that, the clotting of blood in the veins, right? So that is the absence of the anthrombin 3. And then we also mentioned the alpha 2 antiplasmin. Now, this is a protein that is going to play a crucial role in regulation of blood clotting. How? It is a natural inhibitor of plasmin. Now, plasmin is an enzyme that is responsible for breaking down blood clot. Think, think about it. The fibrinogen was converted to fibrin and you formed a mesh. So what plasmin does is that it will come and break down that mesh which was formed, meaning that blood will continue flowing like that. So this is the function of alpha 2 antiplasmin. It is antiplasmin. Plasmin breaks down that mesh which has been formed, meaning that the antiplasmin is going to prevent that breaking of the mesh. So because of that, that is going to help to maintain the stability of blood clot and prevent excessive blood. Imagine plasmin comes and breaks that clot when you are supposed to have blood clotting. Blood is going to be coming out. So what antiplasmin, the alpha 2 antiplasmin does is that it will prevent the operation of this. So this is what we mean by inhibiting the inhibitor. Plasmin inhibits blood clotting, and then alpha 2 antiplasmin is going to inhibit plasmin, which is an inhibitor. So we have inhibiting the inhibitor. All right. We also have alpha 2 macroglobulin, which we can also say A2M. So this one also has anticoagulant properties. It is an anticoagulant, different from the alpha 2 and the alpha 2 and plasmin. The alpha 2 and plasmin, what is it doing? It is actually promoting coagulation, but the alpha 2 macroglobulin is preventing coagulation. So opposite operation. So what it does is that it is going to inhibit proteases involved in blood clotting, such as the thrombin and plasmin. Now, the goodness with alpha 2 macroglobulin is that it will work on whatsoever it wants to work depending on the situation, so that it controls either too much loss of blood or the coagulation of blood where it's not supposed to. If the alpha 2 macroglobulin binds to the thrombin, it means you're not going to form a mesh. There's not going to be blood clotting, and you don't want that to happen inside the blood vessels. If it binds to the plasmin, it means that there is going to be blood clotting, and you want blood clotting to happen if you have got a wound. So that is what alpha 2 macroglobulin is going to do. We also have protein C and protein S. So these are vitamin K dependent proteins, which are part of the anticoagulation system in the body. So what protein C does is that it's going to be activated by what is called the thrombin thrombomodulin complex. And this is in the endothelial cells. This is basically inside the blood vessels. And when you are when you are activating protein C, when the thrombin thrombomodulin complex is activating protein C, that is going to happen in the presence of protein S. And when these are activated, they are going to inhibit coagulation factors 5A and 8A. Now, 5A, this coagulation factor, works together with the coagulation factor 10A and also calcium and lipoproteins in converting prothrombin to thrombin. And so you are inhibiting this one, the 5A, meaning that you are not going to be able to form the prothrombin complex, which converts prothrombin to thrombin, which also will convert fibrinogen to fibrin, which forms a mesh. Okay. And then the 8A is the one which converts the 10 the factor 10, factor 10, this is a clotting factor to activated factor 10. So if we don't have 8 means we are not going to convert factor 10 to activated factor 10, which is part of that complex which converts prothrombin to thrombin, which will then convert fibrinogen to fibrin in that way. And so if we don't have protein C and protein S, we are going to be at an increased risk of venous thrombolism. Why is it like that? Because these two are preventing, remember, they are working on the endothelial cells, inhibiting coagulation. So their deficiency will mean there's going to be coagulation. So if it is in the veins, blood will be clotting in the veins. And that is not good. We also have protein C. Now, protein C is a vitamin K dependent protein. This protein is also going to be activated to activating protein C, which is APC. A is just activating protein C. So it is going to be activated by thrombin. We know that thrombin is the same protease which does convert the fibrinogen to fibrin. So it's the one which is also activating protein C. So it does that in the presence of endothelial cell derived cofactor thrombomodulin. So the conversion of this protein C to the activated protein C is going to happen in the presence of thrombomodulin, which comes, of course, from the endothelial cell. So the activated protein C inactivates factor 5 and also factor 8 in the presence of another vitamin K dependent cofactor protein S, as we already mentioned. So we already mentioned this on the previous slide. So what are we saying? Factor 5 and factor 8 are going to be inhibited. We already mentioned this, all right. Now we have got the plasmin, which is also called as fibrinolysin. This is the active component of what we call plasminogen, which is fibrinolytic system. So what is going to happen here? The plasminogen is inactive. When the fibrinogen is activated, we are now going to have the plasmin. So this enzyme lyses fibrin. This plasmin, which are formed from the plasminogen, is going to lyse, or it breaks down the fibrin and fibrinogen. We know that these are the ones which form the mesh on the wound. Okay, with the production of fibrinogen degradation product, if you get to break these two, that is going to inhibit thrombin. You know that thrombin works actually on the fibrinogen converting into fibrin. Now, if you've broken down fibrin and fibrinogen, it means that you are going to inhibit thrombin. So plasmin is formed from its inactive precursor, as we've said, plasminogen, by the action of thrombin and tissue type plasminogen activator, TPA. So I've got the tissue type plasminogen activator, TPA. This is the one that does what? This is the one that is going to be able to operate on the thrombin. Sorry, not on the thrombin really. We have got a plasminogen converted to plasmin, and that is going to happen by the action of thrombin and tissue plasminogen activator. So these are the two which are able to do this work which we've mentioned here, the conversion of the plasminogen to plasmin. Now, it is also activated by urokinase type plasminogen activator, UPA. So what really are we saying? UPA and TPA, these are able to convert plasminogen to plasmin. And this plasmin is the one now which is going to break down the fibrin and the fibrinogen. And that means that the thrombin is going to be inactive. So if TPA gene and UPA gene is knocked out of mice, some fibrin deposition occurs and clot lysis is slowed. Meaning, if you don't have TPA and you don't have UPA, it means that these clots will not be able to be broken. So you are going to have the formation of clots, and these clots are going to be formed and formed like that. And that is a bad sign. So we have got tissue plasminogen activator, as we've already talked about, TPA, and we've already seen its function. Basically, they are to make sure that it activates the plasminogen to plasmin. So where is this one released? The tissue plasminogen activator TPA is released from vascular endothelial cells following injury, just in the epithelium of the blood vessels after an injury. And then it's going to bind to fibrin and is consequently activated. So after binding to fibrin, that is when the plasminogen tissue activator is going to be activated. So now what is the role of this TPA in fibrinolysis or blood clotting, in breaking down blood clots? So you have got first activation of plasminogen. We know TPA is going to convert fibrin-bound plasminogen into the active form plasmin. The plasmin then is going to act as a proteolytic enzyme breaking down now these different proteins, the fibrins, which is the main structural component of blood clot. So it's going to break it down. So that is what TPA does. Okay. So when that happens, once we have activated plasmin, the plasmin works on the fibrin meshwork that forms blood clot, thereby dissolving it. So we're going to be able to dissolve this clot. So in that case, we are going to be able to. This process is, of course, important for restoring blood flow. Now, you don't want this to happen where there is a wound. You have wounded yourself, and then the plasminogen is converted to plasmin. It will break down that fibrin, meaning blood will continue flowing. This is important inside the body where blood is just flowing, I mean clotting anyhow. Now, we've already mentioned to say that this TPA is bound to fibrin. So what are some significant applications we can mention from here? We have got acute ischemic stroke. So the TPA can be used in the treatment of acute ischemic stroke and also some myocardial infarction or heart attack. So this is basically caused by, you see, blood starting to clot in the blood vessels. So if you want to prevent that, this TPA is going to do a good job by preventing or destroying those clots which have been formed, and then blood will be able to flow well like that. And that is going to prevent this stroke. Okay. So we also mentioned that we have got urokinase. Urokinase also activates plasminogen to plasmin, just the same way as the other one. But urokinase is, of course, a serine protease that this one is going to direct convert plasminogen into the active form plasmin. The plasmin then does the same work of degrading fibrin. So basically, these two are the ones which are the urokinase and the TPA. These are the two which are able to convert the plasminogen to plasmin, which breaks down those clots. So this one, dissolution of fibrin clots, which is called fibrinolysis, as we talked about. What are some therapeutic applications? Acute pulmonary embolism, a blood clot in the lung. There is deep vein thrombosis, blood clot in deep veins, usually in the leg. There is also an arterial thrombosis, peripheral arterial occlusion, and just some other conditions. So you can use urokinase to prevent all this, because you know it is going to stop that blood clotting. It is going to break those clots. And so if you have got, let's say, pulmonary embolism, you are going to destroy those clots in the lungs, and then blood will be able to move well. Okay. Now we've talked about all of these activators of plasminogen to plasmin. You can actually, these same activators which convert plasminogen to plasmin, you can inhibit them by what we call plasminogen activator inhibitors. So what these inhibitors do is that they are going to prevent the conversion of plasminogen to plasmin. Okay, so that is basically what happens in here. So plasmin, we know it is the one which breaks down the clot that we form. So if we don't want that clot to be broken down, then we need the plasminogen activator inhibitors. And basically there are two. We have got the plasminogen activator inhibitor 1 and then the plasminogen activator inhibitor 2. So for the PAI1, this is a primary inhibitor of tissue plasminogen activator. We know that tissue plasminogen activator, the TPA, and also the urokinase plasminogen activator, these are the ones which will convert the plasminogen to plasmin. So what this PA1 does, I1 does is that it's going to be able to prevent the activation of this. If they're not activated, they'll not be able to convert the plasminogen to plasmin. So where are they? Where is the plasminogen activator inhibitor produced? The first one, PAI1, in endothelial cells, just in the epithelium of the blood vessels, in platelets, in adipocyte tissue. What of the plasminogen activator inhibitor 2? Where is it going to be produced, or what is its work? So this one, the second one, is mainly produced by the placenta and is involved in regulating plasminogen activation during pregnancy. Okay, so you regulate plasminogen activation during pregnancy. Imagine the maybe the blood of the baby starts clotting. Just uh, I mean, the mother is hurt. The plasminogen is converted to plasmin, and then it gets to break down that mesh. Blood starts to flow like that. So the plasminogen activator inhibitor 2 is going to work mostly in such a circumstance during pregnancy. It plays a role in preventing excessive fibrinolysis, that is a breaking down of blood clots, thereby maintaining the stability of the developing placenta in this case. All right. Now, where do all these work? We've already talked about all of them. Now, where do they work? The inhibitors and the inhibitors which inhibit the inhibitor. Where do all these work? So when you're talking about blood clotting, we have got different stages of blood clotting. You can, some of these inhibitors, they are going to work on thrombin. So we call them direct thrombin inhibitors. We know thrombin is the one which works on what? Is the one which converts prothrombin. Sorry, thrombin is the one which converts fibrinogen to fibrin. So we can work on the thrombin and will not be able to form fibrin. Or we can work on factor 10. Factor 10 activated is the one which actually converts the prothrombin to thrombin. And the thrombin now converts fibrinogen to fibrin. So we can also work on it. Or we can work on just preventing of blood clotting factor activation. There are a lot of blood clotting factors. We have got those which are involved in the intrinsic, in the extrinsic, and then in the common pathway. In the intrinsic, 12 is going to be activated to 12A. 12A activates 10, 11 to 11A. 11A activates 9 to 9A. 9A activates 8 to 8A. And then 8A activates 10 to 10A. The 10A now activates prothrombin to thrombin. Thrombin activates fibrinogen to fibrin. And then the fibrin forms a mesh. So that is the intrinsic pathway. And then for the extrinsic pathway, you're going to have the tissue factor, which is factor 3, converting factor 7 to factor 7A. 7A converts now 10 to 10A, and then we are going to have the 10A converting prothrombin to thrombin, and then the thrombin is going to convert the fibrinogen to fibrin, which is forming a mesh. So you can prevent any of those positions of the cascade, and so you are going to have no clotting in that way. So those which are able to prevent thrombin or direct thrombin inhibitors include heparin and direct thrombin inhibitor like dabigatran. These are some of the medicine which are able to do that work. And then those which are able to prevent activation of factor 10, we have got also heparin. There's low molecular weight heparin, direct oral anticoagulants such as rivaroxaban, apixaban, and edoxaban. Those which are able to prevent just the clotting factors, different clotting factors, okay, these are going to act on different factors such as factor 2A. Now the factor 2A, first we have got factor 2 itself is fibrinogen. Fibrinogen converted to factor 2A, which is fibrin. So now I'm mentioning the fibrin. Fibrin, okay. This one is we are talking about is 2. So for factor 1 is the fibrinogen, not the one I'm mentioning here. Okay. So factor 1 fibrin, and then the fibrin is now going to be converted into what works on the fibrin is we're going to have the prothrombin converted to thrombin. That is factor 2 is thrombin, prothrombin converted to thrombin, and then we are going to have now the thrombin working on fibrinogen into fibrin. So just a correction on this one. We have got prothrombin to thrombin. This is factor 2. Prothrombin is factor 2, thrombin is factor 2A. That one is now going to convert fibrinogen, which is factor 1, into fibrin, which is factor 1 activated A. Okay, so that is what happens. We can also prevent factor 9A. So there are different things that we're able to prevent. There is a medicine, warfarin, which is an oral anticoagulant, which we are able to take. This one is going to inhibit the action of vitamin K. Vitamin K is necessary in the production of these factors, like the coagulation factors. So if we don't have the coagulation factors, what is going to happen is that there's not going to be any blood clotting. So it is going to interfere with the synthesis of these factors in the liver where they are produced. So apart from factor 4, of course, and factor 3, because factor 4 is the calcium, factor 3 is a tissue factor. These are produced from different places. The tissue factor is produced in the tissue. Factor 4, which is the calcium, is produced in the plasma. But the others are going to be produced in the liver. So that is going to affect their production. So basically, this is a summary of the anticoagulation process. If we convert plasminogen to plasmin, this one is going to break down the fibrin into fibrin degrading products, so we are not going to have any clot being formed. So what is able to activate the plasminogen to plasmin? We have got urokinase and also tissue plasminogen activator, which is TPA. The ones in red is showing those which are able to prevent that happening. So plasminogen activator inhibitor 1 and 2, we already talked about this, PAI 1 and 2. These are going to be able to prevent tissue plasminogen and also urokinase from converting plasminogen to plasmin. Okay, and then you have got also factor 11A, 12A. These also are going to be able to activate. So this is factor 11A and 12A, uh, kallikrein. These are able to activate plasminogen to plasmin, meaning that we are going to be able to break down that mesh. Now I've got the alpha 2 and plasmin and alpha 2 macroglobulin. We already talked about these. These are going to prevent the activation of the plasmin. If we are not forming plasmin, we said this inhibit the inhibitor. If we don't form the plasmin, then what are we going to have? We are going to have a stable clot which is going to form. We can also prevent the cutting of fibrin to fibrinogen. How? We have got thrombin activatable fibrinolysis inhibitor. So this one will also work here to prevent the breaking down of the clot that has formed. So basically, this is the anticoagulation pathway. Thank you so much for watching. Hope it was helpful.